When determining the treatment for patients with myelofibrosis, I am mindful of two things. First, the patient's prognosis. Are they low, intermediate, or higher risk, depending upon whatever score you choose to use? And the majority of patients are intermediate to high risk, with the minority presenting with a lower risk profile, particularly if we are quite studious in terms of trying to find those risk factors. It's only a minority, perhaps 20% or less, that really are low risk. So I view that the majority are intermediate or high risk. Second, I look to see what is the burden of disease that they're facing. Is there anemia? Are there symptoms? Is there enlargement of the spleen? Is there movement towards acute leukemia? Or is there progression? I say this because the two issues are complementary. The decision-making first begins with should a patient proceed toward a stem cell transplant in the near future or not. I believe that that is a consideration according to our current guidelines for patients with intermediate and high-risk disease, particularly if they're younger. Now, there are many factors that factor into that decision for having a stem cell transplant. Is there a donor? What is the exact prognostic risk for the patient? What is the patient's age? What is the patient's desire toward going to a stem cell transplant? It is one of the most complex medical therapies we can have. It carries with it significant risk. Anyone who says that that is an easy decision for a patient is clearly not the individual facing the decision themselves. So it's a very complex part. So first, I make that decision with the patient: transplant in the near future, transplant in the distant future, or likely no transplant at all. Then we evolve into the discussion of medical therapy. Medical therapy, I think, has the potential to benefit the majority of patients with myelofibrosis. According to our current NCCN guidelines, asymptomatic low-risk patients we may choose to observe or place on a clinical trial. But individuals who are low risk and symptomatic, intermediate 1, or higher risk, we will at least consider medical therapy, potentially with ruxolitinib. The patient that we are discussing is 72 years of age, has intermediate 2 risk disease. So the question arises, should we consider a stem cell transplant for this patient? It would be a discussion. It would be accurate to say that it is the minority of 72-year-old patients who would like to proceed with a stem cell transplant, have an appropriate donor, and are felt to overall be good candidates for stem cell transplantation. In the majority of such individuals, we likely would go with medical therapy, but as with all things, there are exceptions depending upon the physiologic health of the patient, how aggressive they really wish to be in terms of their health care, and clearly the resources available to them.